Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This Medscape conference about targeting diabesity from multiple angles really allowed us to have a substantial new insight. It was all done around our patient case of Mrs. J.K., a 65-year-old retired business lady, who had difficult to control type 2 diabetes. Despite treatment, she was on semaglutide, metformin, empagliflozin, but she still had a BMI of 33. But when you asked her what was her main concern, she was really worried about her diabetes developing, more of the inflammatory arthritis, and what's this going to have an implication for her own retirement. Now, Ms. J.K. was still having problems despite our very good treatment. So the question that we wanted to answer is, might there be more therapeutic options in the future, and what would that look like for us to implement in our clinical practice? Matthias explained how the cardiovascular kidney metabolic syndrome is now considered, how we can actually look through the stages, where we have stage 0, a healthy patient, stage 1, where there's excessive and dysfunctional adipose tissue that's developing, until we actually get organ dysfunction in stage 2, that then in stage 3 results in subclinical disease, be it cardiovascular disease or chronic kidney disease. Of course, stage 4 is where we have established disease, and that is what we want to work very strongly to prevent to the best of our ability. So understanding that this is a continuum and understanding how we can intervene and stop this from happening, is what we discussed during this meeting. Now, a question that consistently comes up is exactly how much weight loss do you have to disrupt these complications of obesity? And what we see is double-digit weight loss for most of the complications, is really required. Certain complications, for example, putting type 2 diabetes into remission, we need at least 15% weight loss. If we think about sleep apnea, again, maybe more 15% weight loss. So we need to be ambitious because if we want to disrupt these conditions, we need to have double-digit weight loss, and very often 15-20% weight loss is where we need to be. And that really will drive this health gain that we're looking at. Now we have lots of different options, be it lifestyle treatments, pharmacotherapy, endoscopic procedures, as well as surgical procedures. And of course, as we have increased efficacy, but also potentially increased risk. And what that implies is that we also have to struggle with scalability. And the sweet spot, as Matthias outlined, may be around medications, because this is something that is scalable, and especially if we can have efficacy that improves with better tolerability profiles, this is something that we can apply to large proportions in the population. However, all of these options remain in play, and we need more of each of those. We need more pharmacotherapy, we need more nutritional therapy, more exercise therapies, but also more surgical therapies. And ultimately, Kirsty also talked about how we can combine this in a better way. But when we look at our interventions, be it nutritional therapies, pharmacotherapies, or even surgical therapies, we see this perfect Gaussian distribution. We see that we have responders and non-responders. And unfortunately, we don't have the ability to predict before we start who is going to respond and who may not respond. What we are clear about is it's not the smart people that listen to us that have a good response, and the patients that don't listen, that don't respond. It is biology. So allowing us to understand the biological nature of this disease, and when we apply biological treatments, we end up with a biological result. But understanding this variability allows us to manage our patients' expectations before we start, so that we can have those conversations at 1 or 2 years that is not as challenging. So we do not want to have disappointment, but we can prevent this by having early conversations about the biology of the disease. But also, if we think about any of our treatments, be it nutritional therapies, pharmacotherapy, or surgical therapies, they only work as long as we apply them. And we can see with the pharmacotherapies that the weight loss takes approximately 1 year or 18 months for us to get to our nadir. But if we discontinue the treatment, then what we see is that the patients regain weight. That's not because the patients are not adhering to lifestyle treatment or they're not trying hard enough. It's simply that we no longer have control of this disease. And that's something that was addressed in the question and answer session when we're thinking about controlling the disease and, changing the biological adipocyte mass that is regulated. And the minute we have control with effective therapies, nutritional therapies, pharmacotherapies, or surgical therapy, we can reduce the adipocyte mass volume that is controlled. But the minute we discontinue our treatment, then we see the adipocyte mass will go back to where we started. And that's a critical question of many of our patients. Doctor, when can I stop the intervention? And explaining the biology allows us to prevent our patients being disillusioned or disappointed if they want to discontinue our therapies. So what do we have in the pipeline? And it is very, very exciting if we think about how the new treatments are developing. And of course, we have been accustomed to what we already have approval for in many jurisdictions, for example, liraglutide and semaglutide, that's focused on GLP-1 agonism, but also we combine with a GIP agonism, and we now have tirzepatide and other treatments in development. But what we discussed in some detail is maritide, a combination of an antibody against GIP and a GLP-1 agonism. We also talked about the combinations of glucagon and GLP-1 in treatments such as survodutide and mazdutide. If we combine GLP-1, GIP, and glucagon in retatrutide, then we also have additional benefits. And if we combine semaglutide with cagrilintide in so-called CagriSema, where we hit both amylin and GLP-1, we have other benefits. And that's where amycretin is creating quite a lot of excitement, because it's a single molecule that also hits the receptors of both GLP-1 and amylin. And we also have other treatments where we combine also GLP-2, and we're going to talk about bimagrumab, where we actually have different approaches, where we're addressing both skeletal muscle, but also the brain in GLP-1. So we have a plethora of excitement coming towards us. Now we have to think about how are we going to apply this? How are we going to understand the data? And then how are we going to explain it to our patients and make it practical for us to use? Now, when we are looking at the data, what we are seeing is that most of the phase 2 studies show a clear dose response. Maritide, when we're actually only looking at 52-week data, we see that the plateau has not been reached. So therefore, it suggests to us that if we can go out to 18 months, we're going to have even more weight loss. So that is the combination of a GLP-1 and an antibody against GIP. And it's intriguing that it is working in a very similar way to combining GLP-1 with agonism of GIP. So much more understanding is needed in thinking about these, on the face of it, different mechanisms. Now, combining GLP-1 with glucagon, for example, mazdutide, we see another clear dose response and weight loss, in excess of 15%. And that's also what we see with survodutide. So 2 different compounds in a similar class. And that's a challenge for us now to think about, are these a single class of treatments with GLP-1 backbone, or in fact, are we thinking about these as different classes? Is a combination of GLP-1 and glucagon a different class to, for example, GLP-1 and GIP? So another bit of discussion that we had to understand how we need to think about this in this rapidly evolving field. Now, retatrutide combines all 3 components, GLP-1, GIP, and glucagon. And in a phase 2 study, we see 24% weight loss at 48 weeks. And again, the curves haven't reached a plateau. We're waiting for the phase 3 studies that's going to read out in the next 12 months. And that is going to be an exciting time to understand, can we go beyond 25% weight loss? And, again, what are our response rate? How many responders do we have? How many non-responders do we have? And how are we going to use these treatments? But now we are seeing it's not only about weight loss, it's about health gain. And diving into the liver, especially those patients with metabolic-associated steatohepatitis, we see effects, especially with those treatments that have glucagon components, that go beyond weight loss, where we can see changes not only in liver fat infiltration, but also with survodutide, so the fibrosis. And that's something that we genuinely did not know was possible, because many of us were taught at medical school fibrosis is a one-way traffic. But now we see if we can change the metabolic milieu, anything that can go from left to right can also go from right to left, and we can change this. And that's exciting, because now we are thinking about the cardio, kidney, metabolic disease burden of many of our patients, such as our patient JK, and how we can address multiple components with our treatments. Now, CagriSema, where we hit both amylin and GLP-1, has shown that we can get more than 22% weight loss in the phase 3 studies and additional benefits. But we see that there's always a side effect profile that we can improve on. So we are learning about the dose responses, and sometimes we're a little bit too aggressive in our clinical trials. So how are we going to implement a more gentle program in clinical practice, where we're going to have far fewer side effects, but yet maintain the efficacy? So those are questions that we need to continue to discuss as we evolve. But looking again at the weight loss independent benefits, for example, of CagriSema, we see these impressive improvements in glycemia in patients with type 2 diabetes, where we very often can go to a glycemic level where I can no longer diagnose the disease of diabetes if I didn't know the patient was on CagriSema. And this happens very early on, before the weight loss is plateauing. Now, amycretin holds a huge amount of potential. We can see, even at 36 weeks, more than 20% weight loss, with the curve still going down. So how are we going to implement that in a phase 3 program, and how are we going to reduce the side effects by maintaining all of these benefits? Because we want to have maximum benefit for our patient without the side effects. So with bimagrumab, the rationale really is about weight loss interventions that result in adipocyte mass reduction, but we also see some muscle reduction. So how can we prevent that and attenuate that? And that's exciting when we're going to combine bimagrumab with semaglutide, where we can see the weight loss is additive. But when we actually look at the muscle mass, what we see is, despite the additional weight loss of combining these two treatments, we have less muscle mass loss. So we are preventing the muscle mass. Now that's very exciting because we can have a lot of benefits and we can reduce our downsides. So the most pronounced metabolic improvements have been shown in hemoglobin A1C, in triglycerides, and systolic blood pressure. The main side effects in most of our treatments are what we have come to know: nausea, constipation, and I think we can do much better at reducing that. So allow me to summarize and say, how might this benefit to our patient, combining GLP-1 with GIP, having this additional weight loss, with glucagon having additional liver targets, with amylin where we can have more weight loss and improved glycemia, and with bimagrumab where we can have muscle sparing. So this is a call to action where the evidence base is growing for strategies of enhanced glycemic control, more weight loss, more health gain, and we need to consider how to implement this in our patients, because we are no longer going to pursue weight loss, we are going to pursue health gain and allow our patients to live longer and to live better.